Λοιπόν, να προχωρήσουμε στην επόμενη ομιλία. Είναι πάνω στον χειρουργείο διάσωσης, γίνεται διαδικτυακά. Είναι από το Γιώργιο Γκαρά. Είναι χειρουργός κεφαλής και τεραχείλου, τον λαριγκολόγος, consultant στο Queen Elizabeth Queen Mary Hospital στο Birmingham. Και ένα disclosure, έχω την χαρά να το γνωρίσω τον Γιώργο από την εποχή που ήταν φοιτητής, πράγμα που δείχνει μάλλον την ηλικία μου. Λοιπόν, Γιώργο.
Ευχαριστώ πάρα πολύ, Χρήστο. Τιμή μου. Καταρχήν, βλέπετε την παρουσία.
Δεν φαίνεται την παρουσία. Φαίνεται απλώς.
Στο PowerPoint το βλέπετε.
Ναι, μια χαρά.
Ωραία, τέλεια. Ευχαριστώ πάρα πολύ. Θα κάνω την παρουσίαση στα αγγλικά. Thank you. So the subject I've been asked to speak about is about salvage surgery today. So just to start and say that I haven't got any conflicts of interest to declare. So if we start with an overview of this presentation. So over the next 20 minutes, we're going to briefly discuss what is the definition actually of recurrent and residual disease. And then also mention a bit about post-treatment surveillance, because this is extremely important in the early timely detection of the presence of recurrent or residual disease, which may actually impact on survival. And then we're going to move on swiftly to the surgical salvage options in the context of recurrent laryngeal cancer to follow from my previous lecture. And both in terms of a minimal invasive approaches and also salvage total laryngectomy. And we're going to discuss optimization of the surgical outcomes. So starting with the definition of local recurrence. So there is actually no, or there wasn't until recently, a uniform definition of what recurrence constitutes. But there's a paper last year from some of my colleagues here in Birmingham, where essentially they have proposed certain criteria, including the following three, basically. So it needs to be in the same anatomical site, or if it is in an adjacent subsite, it needs to be within 3 centimeters of where the primary was. The time interval, there is a threshold of up to 3 years. That time refers to time following completion of treatment. And finally, the third criterion relates specifically to the oropharyngeal cancer, that the P16 status needs to be the same, because obviously if the P16 status differs, then we're talking about a metachronous second primary as opposed to a recurrence of the same tumor. And this is very important because the whole biology of the tumor will be different. So moving on to post-treatment surveillance. We published earlier this year this paper, which is open access, so you can read if you want, on the national practice throughout the United Kingdom of post-treatment surveillance for head and neck cancer. And what I'll do, I'll present very briefly certain points that are relevant to this lecture and salvage surgery. So this study included over 5,000 patients from 89 UK hospitals, oncological hospitals. And the points that are relevant here and very important is, first of all, that if you look at the rates of recurrence, these were far higher in the patients who actually, in the patients who expedited their appointments, as opposed to those who were picked up during planned follow-up. You can see here the difference, 35 versus 5.2%, with a highly statistically significant p-value. But more importantly, this is very clinically significant, clinically important, because what it tells us here is it brings into question our current surveillance protocol. I don't have time to go through that now, but what I want to point from that is when we looked at the expedited appointments, the vast majority of those patients who ended up having the recurrence, they were initiated by the patient themselves as opposed to the clinician. And the patients presented with new symptoms. So what I'm trying to say here, in other words, is that it may well be that the patients are much better in detecting their recurrence in a timely manner compared to us, despite our expertise. And it takes us back to the point of listening to the patient and so on. What we did is we looked at those new symptoms and measured the positive predictive value for recurrence for each and ranked them. And you can see here that, for example, new dyspnea or new pain are absolute red flags in terms of suggesting the presence of recurrence. So any patient with those two in particular symptoms in the context of obviously the treatment they received, should immediately initiate investigation. So I'm going to stop, but just wanted to show this point here about that. Let's move on to the salvage surgery per se. When we talk about recurrent laryngeal cancer, it's very important to understand, first of all, that up to 30% of patients with laryngeal cancer will go on to develop a recurrence. And that's a pretty high number, actually, about 1 in 3 patients. Moreover, what is important to understand is that if you look at all the head and neck cancer sites, laryngeal cancer actually has the best salvage rates. Still not good, or approaching 50%, but far better than many other sites and subsites, like, for example, hypopharynx. So recurrent disease, radiorecurrence in laryngeal cancer is common, and it is potentially salvageable in half of cases. But it is a particularly challenging thing to do. It's not always as straightforward. If you, just to illustrate some examples here, if you look at the top left, you've got a classical post-chemoradiotherapy larynx with mucosal edema, loads of secretions, thickened secretions. You can't really see anything much beyond the supraglottis, really. So if you were trying to survey glottic cancer or hypopharyngeal cancer there, post-chemoradiotherapy, that would be very difficult in this case. Similarly, the effects of radiotherapy and/or chemoradiotherapy can sometimes mimic very closely the symptoms of recurrence itself. So if you look at the scans there, radionecrosis, chondronecrosis of the thyroid cartilage, and dysfunctional larynx will manifest with new dyspnea, likely with swallowing problems, aspiration, pain, which is very difficult to distinguish with the presence of recurrent disease. And thirdly, recurrence can be submucosal. So if you look on your right, the post-radiotherapy, you've got erythema is still there, but improving, not much edema, but the recurrent disease was there, and it's easy to miss it with biopsy from an experienced person, because if it's a superficial biopsy, you can end up with a false negative, which can have massive implications in terms of delay of diagnosis. So it's not all that straightforward. Let's move on to specifically the salvage, the surgical salvage for radiorecurrent laryngeal cancer. Broadly speaking, there are 2 approaches here. One is laryngeal conservation options, so organ preservation, and the other one is salvage total laryngectomy. And let's look at this. If we start with laryngeal conservation, this can be broadly subdivided again into the open and the minimal invasive endoscopic approaches, transoral. So in terms of open, there's a multitude of techniques that are being performed depending on the site of the recurrence, which could be, for example, supraglottic laryngectomy, supracrical laryngectomy, vertical hemilaryngectomy, or extended vertical frontolateral, and so on. Most of this, in terms of the recurrent disease, can also be performed endoscopically, primarily with a laser, transura laser surgery, and in a small subgroup for the supraglottic recurrences, you can also do TORS. So essentially, if you're trying to salvage the radiorecurrent larynx, you can do this when you try to conserve in an open manner or endoscopic manner. And what's better? Well, obviously, that's not a straightforward answer. But if you try to look, I think the best paper that is probably there is by Ramakrishnan, in terms of a meta-analysis of the literature, looking at the role of TLM for recurrence, and then trying to compare this against the open partial approach. And the key message here is that the open partial is superior oncologically. It has a better local control rate compared to transoral laser. However, on the counter side, transoral laser is something that you can repeat, and you can go back and clear it up in a few weeks down the line. So actually, it's not a one-off approach. But the most important thing that takes us back to patient selection and decision-making is that these approaches, and particularly open partial laryngectomy, there is only a very small cohort of patients that are actually suited for that approach in the first place. And there are many reasons for that. You have to appreciate that these patients will aspirate. This is not a risk, this is a given with open partial laryngectomy, because you're going to compromise the constrictors and so on. And those patients have to have the respiratory reserve to tolerate this aspiration until they are appropriately rehabilitated. Not many patients that have laryngeal cancer will be, because as you know, these usually are heavy smokers and will have COPD. The patient needs to be very, very motivated. The rehabilitation process with open partial laryngectomy is very long. It can take several weeks. It needs an active multidisciplinary input with speech and language therapists, with dietitians, and so on. And not every patient will have the mental stamina to go through that, let alone the financial ability. So that takes me back to the Transura laser. And the advantage there is that although it is slightly lower control rate, it's something that you can repeat. The recovery period is much shorter because there's no disruption of the pharynx or other structures. And of course, they may well be, and probably will be, an element of aspiration, depending on what you have to resect and where the disease is. But still, it's a much, much faster recovery period for the patient and easier to survey as well. So it's not black and white. It's all about experience, patient selection, multidisciplinary, personalized decision-making. Rehabilitation, I'm reiterating the importance of multidisciplinary input here. This is a very nice paper from some of my colleagues in Birmingham, along with others in London, about the protocol we use here in Birmingham for rehabilitating patients following open partial laryngectomy. So let's move on now to salvage total laryngectomy. Despite all the techniques and all the innovation evolutions with either open partial, Transura laser, Transura robotic surgery, total laryngectomy remains the standard of care for radiorecurrent laryngeal cancer. There are many reasons for that. First of all, the majority of the radiorecurrent disease post-radiotherapy will be advanced disease to start with. But the interesting thing is that even if you look at the radiorecurrent early tumors, so the RT1s and the RT2s, about 70% of them will still require a total laryngectomy for salvage. And there are many reasons for that. One of the reasons is that all these open partial or other approaches, because they will compromise the functionality of the larynx, although you may get oncological clearance, if you have a non-functional larynx and you're constantly aspirating, for example, post-operatively, you'll still end up having a salvage total laryngectomy purely to stop the recurrent aspiration, because otherwise the alternative will still be a permanent tracheostomy and or a PEG as well, or a rig. So it's not just about oncological indications, it's also about functional indications. It is not uncommon for patients, even cured patients following radiotherapy, still ending up having salvage laryngectomy for functional reasons. An example being also chondronecrosis. So, salvage total laryngectomy. The first thing to say is that this operation is a completely different operation from primary total laryngectomy. The increase in the risk profile and the complications is massive. And this is even in the best of hands in the highest volume centers, whether here United Kingdom or United States or Europe or anywhere really. So if you look at the literature, the complication rate is reported as high as 67%. But more importantly, if you look at pharyngocutaneous fistula rate, which is the most common complication, even in the best centers in the world, the lowest rates are usually around 28 to 30%. In other words, about 1 in 3 patients in the best of hands will develop this catastrophic complication. And usually this is much higher in most units, unfortunately. But why is that such a horrific complication? It's the nightmare of all of us as head and neck surgeons. Because once your patient has developed a pharyngocutaneous fistula, then this patient is going to stay in hospital for a long time, several weeks, sometimes it can be even months, unfortunately. You have to realize that this increased length of stay will have an impact on the patient's psychology, on their family, on their finance. These patients very often will require reoperations, and this is already a very highly comorbid patient group. And the development of fistula increases the mortality substantially. There are many mechanisms. It can be because of aspiration, if saliva keeps on drooling into the unprotected tracheobronchial tree. If you have saliva dripping into the neck, these patients develop horrific infections that end up having to be constantly taken back to theater for washouts and drainages. And of course, mortality from carotid blowouts and the major vessel blowouts like IJV from the protease and the lysozyme and other enzymes the saliva has. So this is a very, very serious complication. And to reiterate my point about it being a different story salvage compared to primary laryngectomy, you can see that the fistula rate is double for salvage surgery. So what's the best treatment for treating the fistula? The best treatment is actually like anything else in medicine, prevention. So you want to minimize the development of that. And again, that's where patient selection, decision-making, in a multidisciplinary function needs to be done. So these patients, you need to, what's their nutritional status? You need to ensure, you have your dietitian optimize their albumin, their trace elements. If they're diabetic, you need to sort out their glycemic control with your endocrinology colleagues. Make sure they're in a respiratory way with your physiotherapists and respiratory physicians optimized before you even go down that route. But in terms of surgical tips, there are many. I haven't got time to go through everything here now. But the literature, there's one thing that is very consistent, and this is the need for a flap. So when you are offering a salvage total laryngectomy to your patient, you should always offer that along with a flap with your plastic surgery colleague. It doesn't matter, and that is, I'm happy to discuss this in the questions, if that's going to be a free flap, a pedicle flap, if you're going to just put as an onlay on a primary pharyngeal closure, or you're going to augment it and put an interposition flap, but you really need a flap. And the literature consistently, and obviously our own experience, consistently supports that not only does it diminish the risk, reduce the risk of developing a fistula, but also if a fistula does develop, it's usually smaller and is more likely to heal spontaneously and faster. So that's really, really important. The last thing to say from a surgical perspective is the role of prophylactic neck dissection in the salvage setting for radiorecurrent laryngeal cancer. This is a much more contentious subject. The literature is not great. The best paper that I could find is probably this paper that you've got here, which is a systematic review. And the authors here very honestly and nicely summarize the fact that you can't really meta-analyze this. The heterogeneity is immense. For certain outcomes, the I-square exceeds 80%. Most studies are retrospective. And also, for all these and other reasons, you can't really have any evidence-based recommendations. But what you can say is that the occult nodal positive rate in the C and not neck is low, is about 11%, which is well below the threshold of 20% that we usually recommend for prophylactic neck dissection in head and neck surgery. So that, combined with the fact that there's no demonstrable survival advantage, makes it difficult to recommend that. However, that's where your clinical experience and your multidisciplinary input comes into play. I believe there are certain indications where you should strongly consider performing a neck dissection along with your salvage total laryngectomy, even if the neck is N0 clinically. And examples are here: advanced T-stage tumors, supraglottic tumors in particular. For supraglottic tumors, if I do a salvage laryngectomy, I will always perform bilateral neck dissection selective. Transglottic tumors is another category. And also speak with your radiotherapy colleagues, your oncologist. What were the original radiotherapy fields? Where was the neck treated? And if yes, what was the dose given there? Because that will also play a role in terms of whether or not you should be offering it and what's the additional risk to the patient. So to finish off, recurrent laryngeal cancer will happen in up to 1 in 3 patients. And about half of those patients, if picked up in a timely manner, they are potentially salvageable. Despite the innovation with transoral and open approaches, total laryngectomy remains the standard of care in the salvage setting, even for the majority of early stage radiorecurrent tumors. But this operation is associated with very high complication rates and should only be performed by very experienced surgeons in very high volume centers. A prophylactic flap should always be recommended along with salvage total laryngectomy, even if you can achieve primary closure of the pharynx. Just further reading, the national guidelines from Professor Mehana I've put here. This is open access, so you can read that if you want. And just to finish off by saying thank you, and that if anybody's interested, we are running a minimal invasive head and neck surgery symposium in Birmingham early next year. If you're interested, by all means, I'll be delighted. Please contact me. Thank you very much.
Ευχαριστούμε τον κύριο Γάρα. Έχουμε μία ερώτηση, κύριος Παπακοσταντή.
Εξαιρετική παρουσίαση και μοιάζει σαν κάθε επόμενη παρουσίαση σου να είναι καλύτερη από την προηγούμενη. It seems you know your business very well. Απλώς ένα comment όσον αφορά τα flaps και μπορεί να έχει και μας πει και τη γνώμη της κυρία Βλαστού εδώ που έχει τεράστια εμπειρία. Νομίζω ότι the best flap, it doesn't have to be necessarily a free or a local region as long as it has some muscle inside. And my feeling, but also the literature believes that once you have muscle inside, there's a higher chance that you can actually treat any kind of infection. And a lot of those fistulas, obviously, they are infected. They have they're not clean fistulas. So we know very well when we transfer muscles, it's the best way of actually battling an infection of a fistula. So I don't know if...
I agree with that. We all know that the muscle has a better blood supply, and therefore that's why I think
Yeah. Μ' ακούτε? Ναι.
Ναι, ακούγεσαι, Γιώργο.
Συμφωνώ 100% μαζί σας. Δεν είχα χρόνο να πω ακριβώς τα flaps κλπ. Αυτό που ήθελα να πω πιο πολύ είναι ότι συμφωνώ ότι muscle, είτε pectoralis είτε οτιδήποτε, αλλά απλά ήθελα να πω επειδή πολύ, ξέρετε, υπάρχει λίγο political, ας πούμε, πώς να το πω, ανταγωνισμός ως προς το free versus pedicle flap, γι' αυτό το ανέφερα πιο πολύ. Αλλά ναι, απόλυτα συμφωνώ, πρέπει να εμείς και είναι, δηλαδή, είναι standard of care, πρέπει να γίνεται offered από τη στιγμή που πας για salvage laryngectomy, ακόμα και αν έχεις closure primary, βάλε από πάνω ένα on-lay muscle, οπωσδήποτε, ναι.
Δημήτρη, κύριος Μωραΐτης.
Ένα γρήγορο σχόλιο, νομίζω ότι είναι πολύ σημαντικό να γίνεται καλό, αυτό που είπες και στην αρχή, patient selection, γιατί ειδικά για τα less than total laryngectomies, αυτό είναι key για να έχεις καλά αποτελέσματα. Τώρα όσον αφορά την ολική, η αίσθησή μου είναι, γενικώς προετοιμάζουμε όλους ότι μπορεί να χρειαστούν ένα flap. Πολλές φορές στην Ελλάδα δεν κάνουμε free flaps για αυτά, γιατί υπάρχουν πολλά οικονομικά θέματα για τα free flaps.
Και επίσης comorbidities.
Και τα comorbidities, ναι, και σίγουρα τα comorbidities. Αλλά γενικώς στο χειρουργείο, τουλάχιστον στα δικά μας χέρια, εάν έχεις καλό closure και healthy, viable ιστό, χωρίς τάση, φαίνεται ότι εκεί δεν έχουμε leak rates, ακόμα και να μην βάλεις flap. Οπότε, αλλά όλοι ξέρουν ότι μπορεί να τελειώσει το χειρουργείο και να έχουν ένα pec major εκεί ή δεν ξέρω εγώ τι. Αλλά σίγουρα μέσα στο χειρουργείο υπάρχει μια διαφορετική εικόνα για το πώς φαίνονται τα πράγματα, για το αν θα βάλουμε flap ή όχι. Οπότε δεν βάζουμε σε όλους μειοδερματικά flap. Είναι λίγο biased αυτό. Εκεί που έχουμε δει τεράστια διαφορά είναι, και θέλω να μου πεις, είναι στις ακτινονεκρώσεις, όχι τόσο στο salvage για recurrence. Εκεί νομίζω στην ακτινονέκρωση τα πράγματα είναι πιο δύσκολα. Εκεί οι ιστοί είναι γενικώς άθλιοι. Το flap είναι no-brainer εκεί και νομίζω και είναι και πιο δύσκολα τα αποτελέσματα και γενικώς με αυτούς τους ασθενείς είμαι ακόμα πιο επιφυλακτικός. Η εμπειρία σας για τις ακτινονεκρώσεις πώς είναι γενικώς εκεί στο...
Είναι ένα καταστροφικό complication της ακτινοθεραπείας και η εμπειρία μου είναι ότι το μόνο που όχι διαφωνώ, απλά το practice που ήθιστε εδώ πέρα είναι ότι είναι no-brainer το flap, είτε είναι για recurrence, είτε είναι για retinecrosis, αλλά άσχετα με αυτό, συμφωνώ. Το θέμα είναι ότι το tissue είναι τόσο scarred και ο φάρυγγας κλπ, που ακόμα και αν κλείσει, ας πούμε, είναι και το functionality του, δηλαδή τι swallowing θα έχει αυτός ο ασθενής με ένα fibrosed partial, ας πούμε, pharyngectomy. Αλλά για να απαντήσω στην ερώτησή σας, τέλος πάντων, για το radionecrosis, ναι, βάζουμε flap και συνήθως βάζουμε interposition flap, ξέρετε, για να κάνουμε και augment το pharynga ταυτόχρονα, οπότε και να σταματήσουμε το recurrent aspiration, αλλά και να βελτιώσουμε το swallowing του ασθενούς. Γιατί αλλιώς, ξέρετε, θα έχει PEG πάλι, οπότε it defeats the purpose, ας πούμε.
Ενδιαφέροντα για ένα πολύ δύσκολο κομμάτι. Και φαίνεται αυτό, ότι ο ρόλος της ολικής λαριγκεκτομής πλέον έχει μετατοπιστεί σε μεγαλύτερο βαθμό σε περιπτώσεις υποτροπής, όσο έχει μειωθεί ο ρόλος σε primary. Ωραία, ευχαριστούμε πάρα πολύ.